PCCM page 331, leprosy. So with leprosy, you want to notify all cases to the local public health unit. Think of leprosy if you have any unexplained peripheral lesion or any chronic skin lesion which fails to respond to conventional treatment. Because it has a strong social stigma attached, confidentiality is especially important. Leprosy can have a fairly wide range of presentations, but these include skin lesions, nerve pain, numbness and tingling, weakness, ulcers and injuries. Areas of skin discoloration may appear coppery if they're on dark skin or pink on fair skin. You can have limb deformities and chronic ulceration and scarring on hands and feet as a result of trauma to areas, and you get a loss of sensation with these. You can have weakness, particularly in the small joints in hands and feet, sharp shooting pains, though they're rare, eye pain and worsening vision, lag ophthalmos, which is unable to completely close eyes, and loss of eyebrows and eyelashes. The key is to obtain a complete patient history, inquire specifically about the presence and duration of lesions, nerve pain, numbness and tingling, weakness, ulcers and injuries, eye pain and worsening vision, do your normal OBS. Physical exam includes inspect and palpate the entire skin surface for lesions. These can include macules, which are flat, papules, which are raised, plaques, like psoriasis, nodules, and urticarial-like lesions. Patches may appear coppery on dark skin and pink on fair skin. Sometimes the only lesions may be on the buttocks. With skin lesions, good immunity, tubercular leprosy is characterized pale patches, which are never totally white, maybe red and light skins, single or few in number with well demarcated edge. You can have anesthesia to light touch, destruction of hair follicles and loss of sweat and sebaceous glands. And little or no immunity, so lepromatous leprosy is characterized by skin lesions that are multiple, often no coppery or violaceous colour. No anesthesia to touch and showing leprosy bacilli on skin smears. In terms of nerve damage, peripheral neuropathy affects most commonly the ulnar nerve, which is thickened and may be tender in the groove behind the elbow. Damage to the ulnar nerve leads to anesthesia first, then to loss of motor function, then to deformity in the areas of the fourth and fifth fingers. Other nerves commonly involved are posterior tibial, so you get anesthesia on the sole of the foot. Common perineal nerve, so you get foot drop. Radial nerve with wrist drop. Facial, so lag ophthalmos, inability to fully close the eye. And the trigeminal nerve, which leads to corneal anesthesia. You can have nerve damage. We can have leprosy affecting the nose, so with a mucoid discharge with high levels of bacteria, ulceration of the mucosa, and maybe destruction of the septum and adjacent bone. Leprosy can affect the eyes with iritis and corneal scarring and other lesions. Infected lymph glands or testicular atrophy. In terms of management, contact the MO. Untreated acute reactions can cause functional loss that can become irreversible very rapidly within hours or days. Multi-dose therapy of undiagnosed cases is the key to achieving cure in the individual and breaking the cycle of transmission. MDT consists of 3 medicines: dapsone, rifampicin and clofazimine. The public health unit will provide contact tracing. In terms of follow-up, you want to ensure the patient is compliant with medicines. Involve your family members as much as possible. Teach each patient to avoid injury, so burns and friction damage. Make sure they get long-term follow-up and lifelong follow-up.